right?
Sorry, Don wanted me to record it and I just remembered. Is that okay?
Yeah, that's fine.
I'll fill him in on the first half.
Okay. Where was I? Oh, yeah. So what you see here on number 14, that is actually a root resorption repair. So it looks like a filling, okay, but that was actually done with a open flap surgery. Okay, so perio actually did that. However, you'll note that on number 14, there is a periapical radiolucency associated with it. Okay. And then lastly, actually on number 18, okay, there is also radiolucency right there. It looks kind of odd, okay, because clinically, I could not stick my Explorer anywhere around that tooth. Okay, so to me, that is most likely root resorption, not caries. Okay, so because there was root resorption number 14 and then suspected root resorption on number 18, we decided to get a CBCT to fully assess the situation. And I wasn't going to screenshot every tooth from the CBCT to show you guys, so you just have to believe what I'm about to tell you. Okay, so this is what I found, and this has been confirmed with radiology. Okay, as you can see, he has root resorption on 11 teeth, okay, highlighted in yellow. As an example, you can see in the upper left photo there, that's root resorption on number 13, okay? However, all these teeth are asymptomatic, okay, and without signs of apical periodontitis, and they respond, I wouldn't say normally to cold, but they do respond to cold, and it doesn't really linger, okay? But he gets pissed when you cold test him. As for number 8 and 9, more than 50% of their buccal plates have dehiscence, okay, shown by the red arrows there, okay, likely contributing to their class 3 mobility. As for number 14, the parl is likely a direct result of the root resorption repair procedure, because as you can see in the picture there with the green arrow, the restorative material has impinged on the pulp chamber. Okay, so, and no endo has been done on that tooth. So it makes sense that there's a parl there. And due to the proximity of that root, okay, number 14's root to the maxillary sinus, the opacity in the sinus is likely a direct cause of by number 14. So, okay, you always want to diagnose your patient and then come up with prognosis. You know, it may sound like gibberish, but it's pretty important. And I just realized I forgot to diagnose him periodontally. But prosthodontically, he is completely dentate. Okay, I know he's missing one of his premolars, but ortho has consolidated everything, so he doesn't have any edentulous spaces. So to me, that's completely dentate. However, according to the Prosthodontic Diagnostic Index, he is class 4, which is the toughest cases to treat because he has an oral manifestation of systemic disease. Okay, and most likely because of that disease, whatever treatment we do may be refractory. Okay, meaning that we may not be able to arrest the situation because of his systemic condition. In terms of occlusal diagnosis, his OVD is acceptable. So there's no reason for me to increase or decrease this OVD, okay? However, his occlusion is pathologic, okay? And signs of pathologic occlusion are obviously mobility, like we've seen, or sometimes if you see fractures, or crazy wear, okay, that could also be signs of pathologic occlusion. He does display primary and secondary occlusal trauma, okay? So primary occlusal trauma is basically trauma that comes directly from excessive forces, right? And that happens because he's lacking posterior support. The back teeth are not protecting the front teeth when he taps, right? And then the secondary occlusal trauma is from maybe normal forces, but a compromised periodontal attachment, right? Because he's had root blunting, okay, so shortened roots, and then he's had basically bone resorption, dehiscence of the buccal plates. So all those things makes the periodontal attachment around the tooth very poor. So even normal forces can cause trauma, Okay. Periodontally, forgot to diagnose him, probably stage 3, I want to say grade C. Not a periodontist, and he's being followed up in perio. But I think despite his bone loss, his hygiene is good. So I don't want to say his perio is caused by plaque or anything like that. Okay, I think it's mostly, again, a manifestation of scleroderma. In terms of orthodontic, dentally, okay, he's class 1. You really look at his molar classification or canine classification, he's close to class 1, but that's because ortho has done work on him. But skeletally, okay, again, I suspect him to be class 3, but I won't know without a SEF analysis. Endodontically, he has all those teeth with external root resorption, and we'll go into that in a little bit, okay? And number 14 obviously has pulpal necrosis with asymptomatic apical periodontitis, associated with most likely sinusitis. Okay, then going to prognosis, obviously N and I put as hopeless because of their mobility. The bone on the buccal is not going to grow back magically, okay, it's gone. And the mobility likely won't get better because of that. Number 14, I put a question mark. I put in hopeless and poor, okay? Only because it's technically not completely hopeless, but there's a lot of things going on with it that may put it in that category, depending on the person you talk to, okay? All the teeth with external root resorption are questionable in nature, okay? Because we have no idea if they're arrested or, you know, if they'll progress, okay? And then number 15, I put as poor prognosis because of the class 3 furcation, which we usually put it into hopeless, but perio says they can maintain it, okay? And then the, you know, the rest of the teeth are fair to good. So I actually, when I talk to patients, when their cases get slightly more complex, I like to simplify things into their big problems, okay? Because, you know, we always get caught up on dental terminology and then we kind of bombard a patient with all these dental jargon and they're like, huh? Like at the end of your treatment planning presentation, and they're like, I have no idea what you just said. Okay, so you want to kind of narrow things down, okay? So I've narrowed his problems down into 3 problems. Number 1, the swelling in the upper left quadrant. Number 2, the rampant external root resorption, okay? And number 3, mobility of his maxillary anterior teeth, okay? So I'm gonna have you guys speak up a little bit now, and we're gonna go into it, okay? So let's talk about etiology. Anyone, what do you think the etiology, what's causing the swelling in that region? We just went over it. Yeah, so Lewis said number 14. Exactly. So it is number 14, okay? Because of the root resorption repair and the impingement on the pulp chamber, that created an infection. Okay, he has periapical radiolucency, and then yeah. But okay, I know I said that the sinusitis is likely caused by number 14 as well, but I cannot really rule out it's not that he has sinusitis that came down, okay, into the dental region to cause this swelling. I can't exactly rule that out, okay? So potentially sinusitis or infection in the sinus could be a cause as well, okay? So let's talk about some treatment options for number 14, okay? And you guys can put it in chat if, you know, you don't want to speak up. Let's go from the most conservative to the most aggressive, okay? What do you think is the most conservative treatment for number 14? Nermit said RCT. Yeah, so you would do a root canal and then you would monitor it, okay? Sure, onlay, cuspal coverage. Yes, so that is the most conservative treatment that you could do, okay? What's next? Let's go a little bit more aggressive now. extraction, right? So sure, you could do root amputation, although I wouldn't really go and do root amputation on him just because of the proximity of that root to the sinus. Okay, I don't want to create a communication there. But yeah, what I had in mind is extract and implant. Okay. However, I would bring up to you, okay, the point that we prosthodontists think a lot about, which is the future. Okay, so yes, exactly, sinus lift would be needed. Okay, but here's something I'm going to bring up. Okay, so if you extract number 14 and place an implant, okay, number 15, like I said, maybe have poor prognosis because of that distal class 3 furcation, which periosis they can maintain. Okay, but it may go at some point. Okay, so then let's say 14 goes, you put an implant, and then 15, 5 years down the road goes, you do another implant, and then 13, as I showed you in the CBCT, has root resorption as well, right? And it's pretty severe root resorption, and that's gonna eventually go at some point. And then would you place another implant there? So he ends up with 3 implants for 3 teeth. So that's not wrong, by the way. Okay, but that is gonna be more time and money for the patient in the long term. So what I always do is I always not predict, but kind of go a few years ahead, and also give a patient an option of taking 13 to 15 out and maybe do 2 implants and FPD at this point. Okay, so again, may seem aggressive. That's why it's towards the end here. Okay, some patients will go for it, some patients won't. Okay, but you do want to give them that option. And how do you remove the granulation tissue from sinus? That's what Sadaf asked. You will have to ask an ENT. A lot of times they go through the nose with an endoscope. They can actually, they're basically, they can kind of clean it out with a little robot. Okay, or if there's a communication, then you can go intraorally. Okay, but I don't do that. ENTs or oral surgeons do. Okay, so let's talk about sinusitis, because I said there's a low chance that this swelling could be from the infection in a sinus. Okay, so what would you as a dentist do for sinusitis? Most conservative. What would dentists do?
Antibiotics.
You could do an antibiotic. You could. If it was me, I prefer to just let the ENT deal with it. Okay, because again, I don't want to do more than I have to. Okay, so I work, again, I'm in maxillofacial prosthetics. I work a lot with head and neck and ENT, so I usually just send the cases over there. Okay, but it's not wrong to prescribe antibiotics. But then technically speaking, then you got to really figure out what kind of bacteria is in there, right? You don't want to just, unless you want to prescribe a wide spectrum antibiotic. Okay, so.
Dr. Chao,
Yeah.
so did you do any kind of CBCT to rule out the cyst in the sinus?
I did. We did do a CBCT. That's how we diagnose all the root resorptions, right? So, but I sent that CBCT to his ENT, and then he went to see his ENT. And then so his ENT, after doing a scope through the nose, told me that it's likely caused from the teeth and not anything, crazy in the sinus. So then from that, we ruled out basically non-odontogenic issues, right? So then we can now focus on the teeth. Okay, so since we're talking about implants, okay, do we know about implant survival in scleroderma patients? Because I don't. When I first took on this case, I did not know. And when you're treatment planning and you don't know something, look it up. Okay, no one knows everything. Okay, and if you don't know something, just be humble and go on PubMed and you can look these things up. Unfortunately, though, the data is very, very sparse. Okay, so the only systematic review I found, okay, was published in 2015. And there's only 38 implants in 5 patients with scleroderma. Okay, and the observation period was 38 point. Someone's coming to my office. 38.3 months. So that's like what, 3 years, but with a range of 24 to 60 months. Okay, but the survival rate is pretty good at, on an average of 97.4. So the implants will probably work on these patients because if you really think about it, if it's truly a connective tissue disorder, it shouldn't affect osseointegration all that much. Maybe you can argue the epithelium around the implant, but the bone should be generally okay. So let's now go to the multiple external root resorption. Okay, I mean we kind of already talked about it, but what kind of root resorption is present? Okay, that was the first thought that I had, because the mechanism of action is actually quite different, right? So there's only two kinds. There's internal and there's external. Okay, so from the CBCT, actually I looked through every tooth with the resorption and it's all external. Okay, so it came from outside of a root to inside of the tooth. It didn't originate from the pulp chamber. Okay, so internal root resorption, okay, is caused by classic activity of the pulp cells, while external is from the classic activity of cells in the PDL. Okay, so so for him, it's again external. Now, what do we think the etiology is of his external root resorption? So Dov said ortho. So not technically, right? Ortho. I mean, you could say ortho, but ortho usually you don't see crazy external root resorption everywhere. You could, it's mostly root blunting and maybe sometimes root resorption, but it's not this common to this extent. Okay, so yes, it's the Scleroderma. Okay, so if you look into the Japanese literature, okay, actually there is a lot of, well, not a lot. There's like maybe a couple papers on Scleroderma patients with this exact presentation. Okay, so yes, I do think it's from the Scleroderma. So what does this all mean for Josh? I want someone to answer. So do you think root canals will stop this issue? Exactly. Crystal said no, it won't. Okay, you can't guarantee that after you do a root canal, which is getting rid of the pulp cells, will stop external root resorption, because again, it's from the PDL cells. So we could do a root canal, okay? Gene therapy. I haven't looked that far into it yet, Louis, so I can't say yes or no. But yeah, so the RCT won't actually stop progression. Okay, so we can't really guarantee anything in terms of arrest of the root resorption. But the RCT, if you do it, is to prevent flare-ups, okay, and infection when the resorption does reach the pulp. Okay, and I mean, I wrote there the treatment option, but there is no cure for scleroderma, so you can't really treat this. So honestly, I would say the most conservative treatment is to monitor it. Okay, but what is a more aggressive treatment, which he has done on number 14? Anyone? Before extraction of all teeth. Exactly, root repair. Okay, so Chris said root repair, and likely a root canal if the repair goes towards the pulp. Okay, and then yes, lastly, the most aggressive would be to extract. Okay, but that is really, really aggressive at this point in time, only because it's mostly asymptomatic. Okay, number 14 was only treated because that became symptomatic. All the other teeth are currently asymptomatic, and he's like 50 years old, right? So these teeth have been in there for quite a bit of time. Okay, so to take all the teeth out, it's not a wrong treatment plan. Okay, but again, you'll offer it to the patient, but most likely he'll say no, and he did say no. He looked at me like I'm crazy when I told him that. Okay, so then let's go into the mobility of number 6 to 11. Okay, so what do we think of the cause, the etiology of the mobility? there are a couple things.
Loss,
What's that?
loss on the anterior, 8,
Yes,
9.
so bone loss is one. Okay. What about his occlusion? Remember how his occlusion is not great, right? So
Okay.
it would be because of the traumatic occlusion, okay? And then like you said, reduced periodontal support because he has no buccal plate. And then maybe some root blunting from the ortho, okay? So let's start with the lack of posterior support, okay? Because before we do anything, we gotta give him posterior support, or else the front teeth are just gonna continually get beat up, okay? So what is the most conservative way, okay, to give him some posterior support?
RPD.
Lewis said enamelplasty. That is one of the options, but that is not the most conservative.
Can you do RPD?
What's that?
RPD? No, or I honestly, I don't know.
Okay. There we go. That's good. Ortho. Okay, it's ortho. Ortho is conservative in that you're not grinding away tooth structure. You're not doing any sort of, restorative dentistry per se, right? So because his mandibular anteriors are super erupted, you could either intrude those or you can extrude the mandibular posteriors. Although, depending on the movement, your orthodontist may tell you that the movement is not too easy and you can't really do it without tats. So, you got to talk to your ortho to really find out. But again, the patient doesn't want ortho here. He's had ortho before. He doesn't want to go back into braces. So what is the next most conservative way? Oh, someone already said it. Raquel said it, actually. It's a direct message, though. She said build up. Yes, so it's an additive procedure, okay? So all the spaces that you see in the back, you can do onlace, okay? Minimal prep, bond onlace onto all the posterior teeth. Mandibular posteriors, most likely, okay? And if there's an existing crown, probably recrown it to give him posterior occlusion, okay? Then lastly, we talk about subtractive, right? Which, as Lewis suggested, is enamelplasty or occlusal equilibration on most likely the mandibular anterior teeth because they're a little bit super erupted. It is a little bit aggressive, okay, but it's quite cheap to do and it's very fast. So it's more of a practical route. And this is honestly, when I talk to the patient, the route that he's thinking of. Okay. So that's good. Now let's talk about potential treatment options for numbers 6 to 11. Okay. And we're most likely going to extract in at 9. They're not really going to tighten up without that bone. So what do you think would be a conservative option on number 6 and 11? And just do know that 6 and 7 and then 10 and 11 still do display some mobility, okay? So this is more pros now, so think pros. RPD, yeah. So Sadaf said RPD. So that's honestly more along the lines of what I'm thinking as the most conservative, okay? Of course, my option was a little bit more aggressive in terms of trying to tighten up those abutments, okay? So I honestly told him I want to double abut 6 and 7 and 10 and 11, then do an RPD, okay? And this, if he doesn't want implants in number 13 to 15, okay, the RPD can replace those teeth too. Okay, so then what is the next option after RPD? This should be very quick here because you guys do this all the time. Sure, I mean, implant, yes, but I wouldn't go there yet. I still think FPD, if I'm gonna double a butt for the RPD option, I most likely will double a butt for the bridge, exactly like Lewis said, okay? So I will, because the goal here is still trying to tighten up 6 and 7 and 10 and 11, right? So I would likely do that, okay? So splint 6 and 11 with an FPD. Of course, the challenge here is to prep 6, 7, 10, 11 to all draw at the same time, okay?
Dr. Chao,
Yeah.
because the root surface of the laterals are not that strong. Would you
Mhm.
put mini screws as implants to support the bridge?
Say that one
Like,
more time.
do you put like mini like implants on the anterior to support it?
To
Because
support
it's gonna
a
be like
natural tooth FPD?
yeah, so it's gonna be like mostly like an implant bridge,
So
but
if you're talking about connecting, or are you talking about purely an implant FPD or talking about connecting implants with natural teeth?
connecting implants with natural teeth.
So some people do that, yes, okay, but however, one caution that I have for that, which that's why I almost never do that, is because whatever implants, even if it's a mini implant, they don't have a PDL, so it's also integrated versus teeth, okay, that have PDL, right? So one actually has movement, one's actually ankylosed. The implant's ankylosed. So when you split those two, there's differential mobility of the two over time. Okay, so usually what you find is that the tooth gets intruded. So long term, it wouldn't last that long. Okay, because
I
of the
see.
difference in mobility. Okay. Yeah, but the next option I have is implants. Okay, and I guess I forgot to put one option in here. Okay, so one option would be, before I even show you my next option, is to replace implant number 8 and 9. Okay, and then you can still splint 6 and 7 and 10 and 11 if you wanted to. Okay, that's an option. But my next option on here that I forgot the number 8 and 9 option. It's just because I forgot. I worked on this kind of quickly. But yeah, so I had an option of taking out 7 and 10 because they do have, class 2 mobility. This is a little bit more aggressive, right? So I take out number 7 and 10, I do 2 implants, and I do an FPD. Okay. Again, when I talked to him, okay, I did not give him any options of like, I did give him the option, but I did not recommend it. I guess that's what I should say, of taking out all his teeth and do a long X, or and basically a full mouth edentulation, because you always have to think about the benefit to the patient, right? So compare these two. If he functioning with natural teeth, okay, and then just treating issues as it comes up, or currently right now take out everything and then replace it with implants. I know to some people, you can kind of compare them, but you have to think about the longevity of the implants too. Remember, he has scleroderma, right? We don't have that much long-term data on scleroderma patients. So to me, whatever time I can buy with his natural teeth, I'm gonna buy. Okay, so then the implants later on can last throughout his life. Okay, so if I can buy 10 years out of his natural teeth and not do implants, I'll probably do that. Okay, because I'm just not that certain that implants will work out forever on him. Okay, and then I had a slide in here to just kind of explain orthos just slightly. Okay,
Wait, Dr.
which is
Chao,
yeah,
I have a question just on the previous slide real quick.
sure.
If you were to do a bridge using like 6 and 7 and 10 and 11, but
Mhm.
7 and 10 are more mobile than 6 and 11, isn't
Yeah.
it true sometimes using like mobile abutment teeth for a bridge could cause the bridge to fail more frequently than
Yes,
stable
it
abutment?
could.
And then
Yeah.
would that cause then 6 and 11 to end up failing or like becoming more
could.
mobile?
It could. Okay, so the key to so if you really want to go back, okay, to using mobile teeth for fixed pros, okay, it's before the days of implants, and this actually started in UPenn, I think, where I went to school, and it's called periopros, okay, periodontal prosthesis. This is before the days of implants. Okay, so patients have perio, you clean them up, there's some mobility, but there's no implants, and these mobile teeth don't serve as great RPD abutments. What do you do? Okay, so what people do is they prep all the remaining abutments and do a roundhouse bridge. Okay, and the key, okay, is cross arch splinting. If you get that curvature, you go across the midline, it usually becomes a little bit more solid. Okay, again, however, if it displays basically if number 7 and 10, by the time I do the bridge, still has class 2 mobility, I wouldn't do it. Okay, I will only do it if it's 1. Okay, so we'll talk about sequencing a little bit, but the first thing that needs to happen, okay, is to basically adjust its occlusion so it's stable in the posterior. Okay, and then what I would do is I would temporarily put him into an FPD. Okay, then I would go through all the implant stuff. Okay, and then I would reassess once the implants are healed. Are these abutments good to go, or do we need to reassess? Okay, you can always pivot. There's no one saying you have to, do your treatment plan and it's set in stone. Okay, you got to be flexible here, and we'll go into sequencing in just a little bit. Okay, so kind of a general thing in ortho, I'll tell you, and it's partly why I think he has this flare and dehiscence of 8 and 9. Okay, again, I can't say 100% because I didn't do a Ceph analysis, but remember I said I suspect that he is skeletally class 3. Okay, and a lot of times what I see with modern day ortho, which I honestly disagree with, okay, is that a lot of times they mask the problem a little bit. Okay, if it's a class 3 patient, okay, if it's not severely class 3, a lot of times what they do is they jump the bite. Okay, so they will flare out the maxillary anteriors and they will retrocline the mandibular anteriors, or a combination of both, or either or combination of both. Okay, the risk of that is sometimes when you flare things out, the tooth comes out of the bony housing. Okay, so the tooth, whenever you do ortho, the angulation of it should usually stay within the bone. Okay, if you flare things out too excessively, okay, the bone is gonna resorb. I know you guys learn about orthodontic extrusion and do it really slowly, right? And then the bone will come with it. Buccal plate, at least from what I've seen, rarely does that. Okay, and again, I'm not an orthodontist, so I may be wrong, but that's what I suspect happened to number 8 and 9. Okay, so yes, Sadaf said camouflage. Yes, it is a technique to camouflage your malocclusion. It's for aesthetics mainly. Okay, so let's put it all together. Let's talk about sequencing. I know this is not a sequencing lecture, but generally you want to sequence everything before you render treatment. Okay, one of my mentors, you guys all know him probably, Dr. Parfitspor. Okay, when he teaches, he says that you should have the lab prescription filled out before you even touch the patient. Okay, everything should be done with a plan, with a sequence, and nothing should be an afterthought. Okay, so especially important with complex cases or cases that require multiple steps. Okay, because you don't want to be like, doing procedure and then oh, like you realize you didn't prepare for something, because that'll look very bad on you. Okay, so this slide is not the actual sequence, but this is just generally what the patient is thinking of doing. Okay, although recently he's kind of flipping back and forth. We haven't started. So for the swelling, he was thinking about taking out 13 to 15 and doing 2 implants and FPD, and he already did an ENT referral. Okay, for the root resorptions, okay, for most of them he wants to monitor and then treat them as they act up. And then as for the mobility of 6 and 11, he wants to do subtractive, basically occlusal equilibration, and then splint the anterior teeth with an FPD. Okay, so let's talk about sequencing a little bit. Okay, so this is going to be a roadmap. Okay, but it doesn't, like I said, it doesn't always go this way, and that's why I always break things up into different phases, right? Like if you do phase 2 and you re-eval the teeth and they're still mobile, you don't need to go to phase 3. You stop and you reassess and you retreatment plan. Okay, you again pivot, be flexible. Okay, so phase 1 would be always elimination of active disease. Okay, you do not go to phase 2, 3, 4, 5 if you don't eliminate active disease. Okay, so active disease, obviously, get rid of number 14. ASAP. Okay, it's causing the swelling. And recently he actually sent me a picture. It's actually draining now. There's a powerless. Okay, and then ENT referral to rule out non-odontogenic causes, and he's already done that. Okay. Then I would do the subtractive occlusal equilibration to at least get the posteriors to contact evenly. Okay, then I would prep and then extract. So I would prep 6, 7, 10, 11 in the same appointment, and then I would take out 8 and 9 at the same appointment and deliver the FPD. Okay, and then I do all my provisionals, all my big provisionals beforehand. So I make a shell and I reline it on the spot. It's a lot faster to me, and then you can make it like look super nice. Okay, then after all that, I will schedule another appointment and then extract 13 and 15. I likely won't place implants immediately, only because there's a site of infection. I want to let that site heal up completely before reassessing if I need sinus lifts, bone grafts, and things like that. And disclaimer, I don't really do my own surgeries anymore, despite them wanting me to, but I don't, surgery is not really for me. But again, you don't want to leave the patient with a big sextant with no teeth, right? So you do want to deliver a immediate interim partial denture. Of course, this one would be a little bit more technique sensitive because that abutment, that number 11, is 1+ mobile, right? So hopefully the splinting will tighten everything up. Then you can use that as a temporary abutment. Okay, so phase 2, I would do reevaluation, and then I would do pre-prosthetic surgery, right? So, like I said, so I basically count implant placement and bone grafting as pre-prosthetic surgery. And then we want to really look at number 6 to 11 to see if they tighten up. Okay, it's at this point, which we'll talk about in a little bit, if they don't tighten up, we may need to pivot, okay, which again, is the other option I gave to the patient, and he's kind of going back and forth. Okay, but let's assume 6 to 11 does tighten up, then we will, do a test drive, okay? So I always, for bigger cases, I provisionalize everything, and I will test it out in provisionals before I go to the final, okay? And your provisionals, honestly, should look like the final restoration. Like it should look really, really nice. The only difference should be the material, okay? The provisional should always, for bigger cases, be your blueprint for the definitive, okay? You let them wear it, let them get used to it, okay? And then you copy it. So, so there's basically no question that it will work, okay? And then obviously phase 4 prosthetic delivery is just doing the 13, 15 implant FPD and 6 to 11 conventional FPD, right? And then lastly, you would need to maintain the patient, right? You don't just finish your restorations and say, hey, bye, I'll never see you again. If you're doing prosthetic or restorative dentistry, you're pretty much married to your patient. That is the one nice thing about other specialties, though, is that you can just say, hey, I take out your tooth, come back for a 1-week follow-up, and I'll really never see you again, right? For restorative dentists and prosthetic dentists, unfortunately, we don't have the luxury of that. So patient management becomes key. And for maintenance, for bigger cases, I always do, for the first year, follow up every 3 months. Okay, do a periodic every 3 months, and you keep doing 3 months until you make sure everything is stable. The patient can cling. There's no more mobility. Only after then do you start doing every 6 months. Then maybe you can say, then come back like, every 6 months. Yeah, but in the beginning you want to kind of follow up pretty closely, right? So I don't have it on my slide. Okay, what happens if number 6 to 11 do not stabilize? Let's say 7 and 10 remain class 2 mobile, right? And then 6 and 11, they're class 1. So I wouldn't really take out teeth with class 1 mobility, but what would you do then? You have to pivot, right? You can't just truck on and then make a FPD that's going to be mobile, like Raquel was saying. Exactly. You go with an implant bridge. Okay. You would probably take out 7 and 10 and do an implant bridge. And you may at that point want to talk talk to the patient about if he really wants to be transitioned to eventually own implants, maybe be more aggressive and take out 6 and 11. That's not wrong. Okay, it's aggressive, but it's not wrong. Okay. So actually, I'll tell you guys, after talking to him and he saw my fees, even though I told him my fees are really high before we started, he wants to do removable now. Okay. So, but number 11, right? Is not a great abutment. So he doesn't even want to do survey crowns in the front. Okay. So he wants to just take out 13 to 15 and then maybe end a 9, but he doesn't want to do survey crowns. Okay. But he wants an RPD. Any ideas? How would that RPD stay in place? Because that canine is not good for an implant abutment, at least at this very moment, because it's mobile.
Could you do composite buttons?
Composite buttons would increase retention for the partial, but it wouldn't really address the problem that the mobility still exists in the abutment. Which premolar? 13 to 15 are gonna go. Sure. So on that side, yes, you can use number 5 and the other teeth as abutments. You don't have to use number 6, but that's on the other side. How about the side of 13 to 15? So yeah, Lewis, so that's the one option that I gave him, but he doesn't want to prep those teeth down for a survey crown and splint it. There's one option that rest prep whole teeth. No, I wouldn't do that. I'll give you a hint. I would still place an implant, maybe one implant. Yeah, exactly. Implant RPD. Okay, so likely what I will do is I'll place an implant on number 13. Okay, then either put an attachment on it or make an implant survey crown on it, and that can serve as my abutment. Okay, so then we can address the mobility. We don't have to use the canine as an abutment. Okay, and then then we don't really need to splint all those crowns anteriorly either. Okay, so that is an option that we're thinking of right now. Although he changes his mind every 5 minutes, so we'll see what he ends up wanting to do. Okay, so with that, I hope that was a somewhat productive discussion, I guess. It's just kind of try and give you guys generally the thinking process, right? Again, I think the takeaway here is detailed examination. Okay, find everything that's wrong in the mouth. Okay, then diagnose everything. Okay, and then lastly, etiology, the source of the problem, the source of the stuff you see in the mouth. Okay, then and only then do you come up with the options. Okay, and then again, with options, no right or wrong. Okay, but you always want to go from the most conservative to the most aggressive. Okay, if you can solve problems in a predictable way with the conservative option, there's no reason to go towards the more aggressive. Okay, so at least that's how I do things, and everyone does things a little bit different. There's always a joke in pros that if you ask 10 prosthodontist questions, you get 11 answers. And that's true because everybody has a way of doing things that works in their hands. Okay, but again, I hope this is just a general outline. I hope you guys kind of have a sneak peek at my thinking process at least, and I hope you took away something from today's it's not really a lecture, just discussion.
Dr. Chao, I have a question.
Yeah.
When you're doing the build, like the crowns on the posterior to get them to contact,
Mm-hmm.
you ever kind of retro engineer it and make them survey crowns just kind of in anticipation of a future RPD?
On the mandibular posteriors?
Yeah, essentially like if they have no posterior contacts.
You could argue to do that. However, I was planning on doing that on the mandibular arch, which the teeth on the lower arch are much more stable than the ones I see on the maxillary. If the mandibular teeth have more issues, then yes, over-engineering is always a good thing to do. However, I would bring up the fact that survey crowns or surveyed onlays, if anyone's ever done those, require more space, right? So you would need to, in your prep, have a rest seat actually, so you can actually have space for the rest seat in the fixed prosthetic. So for him, that would mean more preparation, and it's some people see that as more aggressive. But yes, definitely a good idea, I would say. But I wasn't originally planning on doing that just because I would have had to cut down more of the posterior teeth.
Okay, thank you.
I have a question about like deciding whether to be more conservative or a little bit more aggressive depending on a patient's age. I've heard
Sure.
that some people like try to go like sometimes more aggressive when the patient is younger and can handle like, let's say, an all-on-X surgery, then wait until the patient gets too old where that surgery is more risky. And I'm wondering, like, what's your thought on that idea?
My thought is actually opposite. So do you guys know about Clear Choice? Do you know what that is? So Clear Choice is a corporate dental practice. Okay, it's they hire prosthodontists and oral surgeons and periodontists to do all-on-4s all day long. All day long. You make tons of money, okay? But every patient that goes through the door, okay, gets an all-on-4. Everyone, regardless if teeth can be safe or not. Okay. I mean, if it's borderline, they will say, take it out, let's do an all-on-4. Take it out, let's do an all-on-4. Okay. I personally don't believe that should be the solution. Because again, I believe treatment plan should be tailored towards the specific patient. Okay. But to answer your question, okay, so with the age thing, you're right that age does play some sort of a factor in terms of surgery, meaning usually older patients have more comorbidities that contraindicate severe like very aggressive surgeries, right? But again, to me, that shouldn't be the main reason. Okay, I did 4 zygomatic implants on a 93-year-old. Okay, but he's healthy. Okay, all his doctors cleared him for surgery. So all I'm saying is, it shouldn't be the age that determines, like if he can undergo surgery or not. Okay, it's their medical condition. If they have a severe heart problem, cardio issues, they shouldn't go through surgery. The cardiologist did not clear them, then yeah, don't do surgery on them. But that could be a 20-year-old, that could be a 90-year-old, okay, depending on their heart condition. So to me, with age, is that actually, I think if they're younger, you should try your best to save their teeth if possible, because they have to probably live longer. Okay, if you go ahead and take them all out and do implants right away, okay, they have a longer lifespan most likely, right? And that implant has to last that much longer, right? If you do an implant on, say, a 30-year-old, and let's say he's gonna live up to be 90, how long does that implant have to last? Crazy, 60 years. We don't have any papers on implant follow-up on 60 years. At most, we have like 20, 25, okay? Nothing on 60, okay? So we don't know. So to me, I'm always saying tread carefully. If you can save the tooth and it'll last 5 years, that's 5 years you're buying off of the implant, okay? So that's what I tend to, the philosophy at least I go with. With older patients, then you can argue that they don't have as long to, their lifespan is slightly shorter, then you can go more aggressive and give them one last shot at, just quality of life, right? But again, everything is situational. If you see a 30-year-old, okay, with teeth that are all bombed out, and then you're going to be doing heroic dentistry to save them, obviously I'm not going to, advocate for that, okay? But if they're borderline, they can be saved predictably to some extent, I would try and save.
That makes sense. Thank you.
Mm-hmm.
Dr. Chao, I have a question regarding that option. If we want to build a posterior contact, what would be the process to building the posterior contacts in terms of how many teeth we need to prep, subscribe for a crown? What would be the lab order? Are you changing the VDO based on that? I assume that we are changing the VDO.
So
Yeah.
not necessarily changing the VDO. I'll start off with that, right? Because right now, when he occludes, right, he contacts only on the anterior, right? So let's just say if you purely only wanted to do additive, let's say purely, okay, then yes, you do need to change the OVD slightly so the anteriors are contacting lighter, okay? But most likely what I would do is a combination of both, okay? I do slightly in the anterior and then I build up slightly in the posterior. So I'm not changing all that much, right? So right now when I've mounted the case on my articulator, right? So it shows that he's contacting the anterior, and if you look at the posterior, they're all open. So honestly, the process would be I would basically just wax it up to fill that space on the posterior, okay? Then I would most likely prep and temporize. And then after that, I would just lighten up the anterior ever so slightly, and I would be done. Okay, but if you really want to talk about changing OVD for full mouth rehabilitation, then that's another whole lecture about, you know, the science of occlusal vertical dimension on fixed cases. Then you got to talk about CR, you got to talk about, you know, Turner's classification, you got to talk about prosthetic space. This, you know, it's totally another lecture.
Okay. Thank you.
Yeah. I had a question here. If a patient is old and you have the option of both bridge or implant, which one am I gonna do? Again, situational. Everything is situational, right? If it's a case where the adjacent teeth are already, you know, they show signs of existing restorations, I'm probably gonna do an FPD. Okay, but again, there's some old patients now with pretty darn good teeth, right? Because, you know, the awareness for oral care has been going up. Okay, so in those scenarios, I would do an implant. I don't think age would really be a factor again. Again, when you bring in medical history, though, that's totally a different story, right? Like I see a lot of radiation patients, okay, and let's say they're terminal, they're a stage 4 cancer, and they want us to, you know, do a pre-radiation clearance. And if they're only terminal and they're doing radiation because they're doing it to just alleviate the symptoms, I'm not gonna really go and say, oh, we're gonna take all these teeth out. Okay, if they're stage 4, they're not gonna live that long, and I'm gonna let them keep their teeth and pass like that. I don't want to take all their teeth out, and then whatever time they'll have left, they're dealing with all these edentulous spaces, and then they can't even wear a prosthesis, and their remaining life is horrible. So it's to me, it's more medical history than age. All right. Any other questions? I gotta go feed my cats, actually.